The next speaker is Mark Schlesinger, and first of all, it's my honor, privilege to invite a friend of mine from Yale. And Mark, I don't know if you remember, but other than the folks at the Faculty of Nursing, you were one of the first people I met when I came to Yale. And Mark is the perfect person for this, because if I think of one, well, there are many good words to describe Mark, but Mark likes to ponder. I have to say that, right?
I try to avoid being ponderous.
Right, exactly. And so you'll see in his work, if you haven't already, this beautiful, elegant melding of ideas, concepts, constructs, thinking out of the box, beyond, bringing the discipline, I don't want to say beyond the disciplines, but bringing much of what we all do together. So he is a professor of health policy at the Yale University School of Public Health. He's a fellow in the Yale Institution for Social and Policy Studies, and I'm proud to say I've sat around many a table with him there where we tried to ponder some of these other issues, which is a place similar to the center, bringing together people from disparate backgrounds. He has also been an editor. He's been the past editor of the Journal of Health Politics, Policy and Law. We want to put the politics in there because of our appreciation for the importance in that. And if you haven't read the latest issue, it's right here, October 12th. It's got a great article on crowding out and welfare, and it resonates with much of what we're talking about today. So let me give you, I thought, how do you introduce Mark? Well, so what I decided to do, because when I read his bio, I came up with all these words that were so wonderful. Consumerism, markets, profit, patients, etc. So I'm going to take the bio from here, he knows I'm doing this, to just briefly, hopefully, introduce him and give you a sense of some of the areas he's coming from. His scholarship explores the determinants of public opinion about health and social policy, the influence of bounded rationality on medical consumers, and the consequences of for-profit organizations in American medicine, and the impact of managed care for consumers and healthcare professionals. But we're not done. His recent research initiatives include explaining the rapid expansion in the scope of newborn screening among U.S. states, exploring the origins and implications of economic insecurity for public support of the American welfare state, still not done, and enhancing our understanding of the role of patient narratives in shaping health consumerism, and assessing the potential for patient voices to shape health policy making with greater fidelity. Now that's just one framing of Mark, okay? I'm gonna stop talking and let him go on with his talk. It's 45 minutes, and then we have two wonderful initial brief respondents, discussants, that will follow up. Thank you. Here's Mark.
Thank you, Sally. It's been my general experience that the generosity of an introduction is inversely related to how well the introducer knows you. And so I'm especially grateful that Sally, who's a longtime friend, had such generous words to say. I am also very grateful to all of you who organized this session for inviting me. It's been a great pleasure over the first day, and I think hopefully it will be an equally enjoyable and engaging experience in the second. Little known fact, I was born in New Mexico. I spent the most formative year of my life here. And even though one doesn't really remember all that much between 0 and 1 as in terms of shaping one's personality and professional aspirations, whenever I return here, as I do periodically, I feel this kind of connectedness to the place, to this thing we call New Mexico. And it is altogether fitting that I begin this talk with that kind of framing reference, because I'm going to ask us today to radically shift gears, to, at least for this part of today's conversation, to, for the moment, turn away from those things which create differences, disparities, inequities, and look instead to those things that bond us together, that hold us in common, that make us all see a kind of connection and collective responsibility for one another. And I do so because My concern is that we will not be able to mobilize in an American political culture with its current characteristics. We will not be able to mobilize concern for social disparities or even social determinants of health unless we can rebuild a sense of collective commitment to one another and to one another's health and well-being. And so this is the agenda for my talk today. First, to start with the somewhat bleak task of convincing you that we really do need to worry about our collective sense of commitment to one another, that it is eroding over time in problematic ways, and that only by so doing, only by establishing some common grounds that we all share with one another, can we then get people, a broad swath of the public, to pay serious attention to disparities, in particular to disparities that involve the social determinants of health. Now, this is in some ways a shifting of gears from all that we were talking about in the earlier sessions, but in other ways it is not that big a shift. Importantly, you will hear echoes in my talk today of a number of the things we talked about yesterday and the first session this morning about using established policies like the PPACA to leverage people's attention to these issues of disparities. And even more so, what we're going to do is reconnect with that portion of the WHO document, the Closing the Gap document, that I know a number of you guys read in preparation for this symposium. The very important aspect of that report that talks about governance. And so in that report, and this is a quote, though I didn't put it in quotes, the WHO argues in the aftermath of the Rio conference that the poor progress that is being made around the world, not just in the US, towards thinking about social determinants, partly reflects inadequate governance structures. And they identify a number of those that bridge across health versus non-health agencies, that have legislative constructs that allow us to think about these broad-reaching and long-standing investments. And all those are true. And all those are important and equally apply to the American political context. They also suggest, and again, this is a quote, they're not in quotations, that in order to shift governance to take social determinants more seriously, we need to engage a broader section of the populace to get involved in governance mechanisms. That is also true in the US. And I'm going to suggest today, towards the end of the talk, one possible mechanism that builds on parts of the PPACA that would allow us potentially to do that. But what the WHO report doesn't do is touch on one thing which is unique and distinct to the US, but absolutely essential for all of us to think about, which is that in the US, we have lost our sense of commonality with one another. We have lost our sense of why we should care about one another's health and well-being. And what I'm going to do is try to convince you of that somewhat bleak proposition. And that's going to be our starting point. Now, that's going to be sobering. It ought to be sobering for all of us in this room. And it may feel a little disheartening, particularly for some of you just starting on your professional careers. I want this to be sobering, but I don't want it to be disheartening. And so I'm going to try to come back at the end with some more constructive, positive senses of ways in which we can move forward in a way that will gradually, over time, rebuild this sense of common connectedness. So, why should we even care about this? Well, despite having just enacted the PPACA in 2010, I think there is very clear evidence that our sense of common connection with one another to care about one another's health and well-being has been steadily eroding in the United States. And one marker I'm going to use just to signal that and give you some sense of the magnitude of the erosion is the response you get in public opinion surveys when you ask people, do Americans have a right to health care? Now, I'm sure you've all thought about that. I'm sure you've all heard questions phrased in that way. What I suspect you don't know is how the average American's response to that question has changed over time. In 1968, 87% of the public agreed that as a basic societal right. Americans have a right to health care. By 2012, it was down to less than a third of the public. Now notice those last two bars are in a slightly different color. That's because the wording of the question changed, and so don't take those numbers all that precisely. But there was a clear downward trend, even with constantly worded questions between 68 and 93. These more recent questions just extend the perception. In short, we have lost a willingness to commit to say that as a basic part of American society, everyone has a right to health care. Now, there are lots of hypotheses about what drove this long-term societal trend, long-term and seemingly continuing. Part of it is the increased moralization of health, the increased attribution of individual responsibility for bad health outcomes, blaming the victim, as it was referred to in our talks yesterday. And surely that is part of it. Part of it is associated with a long-term and progressive decline in Americans' trust in government, in particularly the federal government. And when people think about rights, they think about things being enforceable by the federal government. So if you don't trust the government to do it, you don't have the same faith in rights. Part of it is probably attributable to those growing expenses of medical care that Tom Leviste referred to in his opening session yesterday. If rights become so expensive that we can't figure out how we can even possibly afford to them, maybe we stop thinking about rights at all. Now, we don't actually know how much the decline in rights talk is attributable to those factors, but it is a very clear change, and it is not simply semantic. Something very important is going on in terms of our sense of collective commitment. But that's only part of the bleak story. Second plank in the story, that it turns out to be surprisingly difficult to mobilize moral outrage around disparities associated with health outcomes. More so, surprisingly, than disparities associated with health care outcomes. These are the results of a recent study published by Julie Lynch, who's at Penn, and Sarah Gallist, who's at Minnesota. And what they did was give a representative cross-section of about 1,000 Americans some graphical representations of disparities. In other words, these were disparities that were equal in magnitude, equally bad for the disadvantaged groups. And they looked at three kinds of disparities. Disparities in life expectancy, disparities in quality of care, disparities in access to care. And they showed people the numbers graphically. And they said, okay, does this bother you? Does this seem morally wrong to have differences in outcomes that are this great? Notice that when it comes to inequalities of healthcare, about 70% of the public said, yeah, this is pretty unfair. I think this is bad. When it comes to access to care, again, about 70% of the public said, oh, this is pretty bad. Yet when exposed to equally large disparities in terms of life expectancies, only about 30% of the public thought there was something morally problematic with that. Now, that better be disturbing to you, right? Because after all, we want health care only because it's instrumental in producing health. And so why is it that the disparities in the care seem to matter so much more? Again, we don't know for sure, but there are a variety of plausible hypotheses floating around. One hypothesis is that there's enough of a perceived genetic driver in life expectancies, and people say, oh, it's genetics, we can't do anything about it. You know, even if that's a false perception, it may still drive people's opinion about the moral salience of these disparities. Second is that, and there's some pretty good evidence to suggest, that because there is perceived to be greater provider discretion associated with quality of care and access to care, and therefore greater potential for discrimination and all these kind of more discretionary ways of treating people differently, there is a bigger moral culpability assigned to healthcare providers in the second and third category. Again, we don't fully know what's driving these things. One thing we do know is not driving these things is public perceptions of how bad the disparities are in real life. Because we've done surveys of this. This particular data that I'm going to describe for you now is from a set of surveys that Bob Glendon and his colleagues did as part of the Kaiser Harvard ongoing survey enterprise. And in both 1999 and 2006, they asked people, how much worse off are different minority populations in the U.S. in terms of both life expectancy and healthcare quality. They also asked about access. I just didn't put it on the slide. They also asked about infant mortality. I just didn't put it on the slide because the patterns are exactly the same. What you see is that the perceived disparities are, for Latinos, as large in life expectancy as they are perceived to be in quality of care. Now that turns out to be not actually factually accurate, but again, these are public perceptions. And for African Americans, the perceived disparities in life expectancy are perceived to be larger than they are in quality. So it's not the fact that people think that life expectancy differences are trivial. They see them as just as common as they do differences in quality of care. And yet somehow they are giving them different moral salience. But wait, that's not all the bleak story. The third plank in our sad tale has to do with the limited moral saliency of health disparities as opposed to health care disparities in motivating public support for collective action. Now here again we turn back to that earlier study I was describing that Julie Lynch and Sarah Gallis did. And what they did was take the same data that they had on perceptions of inequities, both health-related and healthcare-related, and they cranked them into a model, regression model, where the predicted outcome variable is support for government action to do something about these problems. And in the model, they threw all the typical predictors, political attitudes, socio-demographic characteristics of the respondents that would predict willingness to support government action in healthcare. And importantly, they included measures of both health disparities and healthcare disparities. Now these bars represent the change in support associated with the perception that there are either disparities of health that were either viewed as unfair or very unfair, or disparities in healthcare, unfair or very unfair. It doesn't take a rocket scientist to see these bars are a lot bigger than these bars. In other words, controlling for other political attitudes and socio-demographic characteristics, even the people who thought that health outcomes were unfair, it didn't motivate action very much. But healthcare disparities did motivate action. Now just to give you a standard of comparison, this is how much less support was for government action in healthcare among strong Republicans compared to Democrats. So these are big differences, a lot bigger differences than the political attitudes which we know are so consequential in this debate. So, but wait, we're still not done, because there's one more plank in our sad story, which is that, as best we can tell, and the literature's a little thin in this regard, but as best we can tell, it's hard to get the public to care more about social determinants. Now, in fairness, this is actually like one of those good news, bad news jokes. There's good news here. Because one of the reasons it's hard to get them to care more about social determinants is they already recognize social determinants as being quite consequential. So, what I'm going to present here is just a little snippet from a study I and some colleagues did a few years ago, looking at public perceptions of the perceived causes of the so-called obesity epidemic in the United States. And what we did was describe for them a set of narratives, which are summarized very briefly for you by these little headings here. And the little headings, there's a whole story that went with each of the headings that we described to people, but you can kind of get the idea. Sinful behavior, sloth and gluttony is the cause of it's like bad things, right? The bad things that people do to themselves. Addiction, food addiction, people are addicted to sugary things. That takes away a little bit of the moral culpability for the individual because it's an addiction, but they are eating it, so it's still pretty blameful for them. All the way on down to things where it's the social determinant, industry manipulation of preferences by way of advertising and the like, toxic food environments, things like the food deserts that we were talking about yesterday. Now, importantly, when you actually ask Americans which of these different stories are important explanations, and we had detailed measures of what it meant to be an important explanation, we won't belabor them now, just take for granted that this is a plausible measure. what you could see is that the high blame, high individual responsibility causes were actually about as common as the low blame, social determinants causes. So basically, people get it. People get the fact that something like obesity is influenced by social determinants as well as individual behavior. In fact, the average American basically thought that maybe 3, 4, or 5 different factors were important. Now, this is actually important. We'll come back to this because what it suggests is that Americans actually have pretty sophisticated conceptions of what leads to ill health. Some things are individual, some things are collective. But you're not going to be able to do much to convince people that the social determinants matter when you've already got a high baseline that they already do matter. There have been efforts to try to do that, though, to try to expose people selectively to information, to try to reinforce the importance of social determinants. And these studies tend to find a fairly interesting pattern. And so what I'm going to describe to you is just one of a set of studies that fall into the same general category. This study, again, done by Sarah Gallist and a different set of colleagues, not with Julie Lynch in this case. And what they did in this case was run a little experiment where they exposed 4 different randomly chosen groups to 4 different narratives. The control group got a narrative, in this case this was about diabetes, so related to obesity but with a specific diagnostic label to it. The control group just got a little story that had nothing to do with the outcome. The genetic arm of the experiment got a story that talked all about genetics and its influence on type 1 diabetes. The behavior arm got a story that emphasized individual behaviors, and the social determinants arm, not surprisingly, got a story that emphasized social determinants. And what you can see is that there was a generic pattern that people who got exposed to the genetic story were somewhat less likely to think of diabetes as having been caused by social determinants or social factors. People who got exposed to the social determinant story were somewhat more likely to think. But notice the difference between the black, the gray, and the white bars. Democrats, independents, Republicans. Notice in particular, Republicans were not convinced by social determinants. And this is a very common pattern you see across these studies, that people, when they hear the social determinant story, because Republicans aren't dumb and they realize that social determinants would require government action to deal with, they say, oh gosh, I really don't believe the social determinants, I really don't like government. So there's a lot of partisan resistance to the social determinant story, which again makes it harder to increase the public salience of this as an issue. So when you add all those things together, the idea of actually mobilizing the public in some serious way to think about collective connections with one another, and in particular collective connections around social determinants of health and disparities in social determinants of health, does not look very promising. And so realistically, I think what we need to do is do basically what the IOM did in their unequal treatment report, the one that Tom described yesterday, which is say, look, we know we need to get to the social determinants of health, because that's what we really care about in the end, but we've got to get there by hooking people with something that is a more resonant story for them. And that involves thinking about disparities, unequal outcomes associated with health care as opposed to health, just as a first step on a pathway to get us back to this sense of social commitment. The challenge is that, well, again, good news, bad news. The good news is we know how to build collective connectedness around healthcare. We know from the experience in lots of different countries and from some more targeted population experience in the US. The way you build a sense of collective connection with one another in healthcare is throw everyone in the same pool that's paying for their healthcare all together. So in Canada, it's called Medicare, not to be confused with US Medicare. In the UK, it's called the NHS. In France, it's called their national health. You throw people all together, they develop a sense of common identity and common connection around those things. Worked for Medicare and Medicare beneficiaries in this country. The problem is, it will not have escaped you that we do not have a common financing pool in the US to pay for things. And can't call on that same, not you said, but Mark, wait a second, we just passed the PPACA in 2010. We just spent $900 billion over a 10-year period. We did. The problem was, not only did that not build a common identity, it may have further fragmented our political identities around our sense of connectedness to one another. When you actually look at public support for the PPACA, public support was really high for targeted programs, targeted by income, targeted by other measures of need. 75 to 80% of the public said, if we're going to do healthcare reform, let's really help those most in need. Well, that's good, a little bit on the disparity side, right? Because people are caring about need, they recognize needs different. But support for universalistic programs, Medicare for all those things that would put us in that common pot with one another, that common pool where we could build common identity, that never got above 40 or 45%. And so the Obama administration wisely took the political strategy that didn't emphasize universalistic principles as part of healthcare reform. They emphasized particularistic principles, subsidies for particular people in particular circumstances, of particular levels of generosity. And those are great. Those help people buy insurance, or they will when they eventually go into place in 2004, but they do not build connectedness with one another. So that's a path that, at least at the moment, doesn't look promising. So where else do we go? How else can we find commonality in our healthcare connections that will remind us that we're all in it together in some fundamental way? So what I'm going to do now is propose one possible approach, an approach I particularly like, an approach that I'm pursuing as Sally's introduction described, but one which I think offers at least characteristics that are promising. And I offer it not to say that you guys should all pursue the same approach. No, I'm doing it, you guys don't have to. But I want you to think about commonalities, analogies to other things where we could find connectedness with one another and use that to leverage a concern for the social determinants and health disparities that exist in them. So, the approach I'm going to suggest as just the promising prototype, the archetype for this alternative strategy that I'm urging you guys to at least think about adopting, is to think about using the widespread experience of, I'm going to be very colloquial here, getting screwed by the healthcare system. The point is, we have all gotten screwed by the healthcare system. We have a horrible healthcare financing and delivery system. Apologies to providers, I know a lot of you are doing good, but the system is crappy. And we all get damaged by it. Studies, surveys that I've done, and surveys by other people looking at similar questions suggest that in any given year, 50% of the American public have problems with their health care or their health care financing. So this is a common, reoccurring problem. And they don't know what to do when those problems occur. They're lost. We've all been there, right? We all know through our personal experience and the experience of our families that the system is so complex, so confusing, we do not know what to do when something goes wrong. So my suggestion is, because that's a common experience, we build on that commonality and use that to leverage a sense of connection with one another. A couple of years ago, I and some colleagues, a few political scientists at Yale, were doing a big survey of the public. It happened to be on economic insecurity. That's not relevant here. But among other things we were looking at were the kinds of things that people worried about in their lives. And among those, naturally, we asked about questions about people worrying about their health care. Now, pertinent to our current discussion, when you actually ask people, these are people who have insurance, how many of them worry a lot about not even being able to understand their insurance coverage? 2/3 of them, 2/3 of us say we can't. I mean, if people were honest, it would be 100%. Everyone doesn't understand. Healthy people might not worry because they don't actually have health care to worry about, but everyone who's actually confronted the healthcare system and confronted trying to use a policy knows they cannot figure out their health insurance policies. I'm an expert, I cannot figure out my own. Equally important, though, not only is it a widespread fear, a thing that connects us all together, it's also something that connects us across partisan lines. Yeah, it's true. A few more Democrats say they worry than Republicans, but 60% of Republicans say they worry about not being able to. And equally important, if you look at the level of political engagement of those who say they worry about their health insurance, it's actually the people who are most engaged in politics who are more worried about it. So this, when you think about political mobilization, this is great news, right? We have a common problem, widespread, across party lines, among people who are willing to be politically active. This is the kind of thing I want you guys to be looking for. Find those leverage points. Now, it's not simply consequential in terms of changing political attitudes. It really has an impact on people's lives. We're used to thinking about, and you guys all have seen these statistics and you know the disparities in these statistics, about people who put off medical care because they're afraid it's too expensive. About a third of Americans in any given year say they put off medical care because they're worried about the cost, even those who have insurance. But notice, 20% of Americans put off health care because they just don't know if their insurance policy will pay for it. Just the fear, just the uncertainty, just the anxiety. So, this is big, this is consequential, it has big impact on both attitudes and behaviors. What we need, arguably, is a public infrastructure that can help people deal with these uncertainties, these confusions, that can accompany people, can advocate for people as they move through the healthcare system, and can help them negotiate these complexities. Now, another little known fact, the PPACA actually started funding such a system. But no one knows, well, not no one, a few of us know about it, but hardly anyone knows about it. This system, this effort to re-empower people, and this is again a diagram out of that WHO Closing the Gap report, that brings us back to this quadrant of what it means to connect people to healthcare, to enable and empower people in their healthcare experiences. We know, moreover, that not only are these problems widespread, but from the experience in other countries, that you can use this sense of accompaniment and protection and assistance as a way of trying to build a sense of collective commonality. Possibly the best example of this is found in New Zealand. New Zealand enacted in the late 1990s something that they refer to as a right to complain. Americans should love a right to complain. Right? We don't care about a right to health care, but at least we should have a right to complain. And that's what they have. They literally have a constitutionally guaranteed right to complain about their health care. And they have an office of a healthcare ombudsman that focuses on helping them deal with those complaints, figure out what went wrong, and try to make it better. Now, in New Zealand, because they have a much simpler health insurance system, most of those complaints and most of that recourse, most of the ombuds action is on the delivery side, on the provider behavior side, on discrimination that happens at the provider level. But as you bring it back to the US, where insurance problems are 3 times as common as they are in New Zealand, clearly we need to be thinking about not only care, but also need to be thinking about insurance. Now, as I mentioned, the foundations for this were actually laid as part of the PPAC. Section 1002 established a set of programs called consumer assistance programs and set up a series of federal grants to be made to the states. This is to be a state activity, so states are supposed to run these consumer assistance programs. Now, a number of states already had these programs in existence. And so the CAP program, as it's called, the Consumer Assistance Program, was modeled on these early states. But the idea was, let's make this universal. Let's make sure that all Americans in every state could have access to this kind of support and assistance, and that will be our common bond. That will be our common connection. So, as it was embodied in the legislation and in the several rounds of grants that have been made since 2010, consumer assistance programs as constituted under federal law and operated by the states were supposed to do two different things. First, what the regulations called free and vigorous advocacy. In other words, they're supposed to go in and take the side of the consumer slash patient slash person who's getting screwed by the system and help make things better. And to do so in as freewheeling and non-bureaucratic way as they can possibly manage. Now, for some state agencies, that was hard. Some of the states subcontracted to nonprofits because it was easier for them to do it. But the idea was get in there and get on the side of consumers. That's a good thing. We can all get behind that. Equally important, though, was this second provision that the CAP programs were supposed to aggregate individual experiences to detect systemic patterns, systemic shortfalls in quality, systemic problems in access, and to be able to identify them so that regulators and policymakers could respond to those systemic problems. Again, we have some experience with programs in the past that have tried to do this in targeted areas of the U.S. healthcare system. The Long-Term Care Ombudsman Program, for those of you who do elderly care, will be familiar to you. But we've never tried to do this on a universalistic basis for the mainstream working age population. So, that's the foundation. Those are the aspirations. We now have 2 years of experience with rolling out these CAPS grants and trying to put them into practice. And we know that although they're a promising foundation, they've got some challenges of their own. So again, truth in advertising. Let me tell you about the challenges that come with this. First, because they were part of the PPACA, part of Obamacare, as Republicans like to call it, they faced extreme partisan opposition. So even though the federal government was giving away free money, as they like to say, 15 states, all under Republican governors, refused to even apply for the money. It's a horrible moment. For them, the political consequences were worse than not helping out their constituents actually get health care. Even more curious is that between the time that the grants were initially let in the summer of 2010, the first round of grants, and when they actually went into place in the fall, there was an election in 2010, and some states went Republican, and 2 of the states that went Republican gave back the grants they had been given. So Wisconsin and Ohio got a CAP grant, and they just gave it back unspent. So, trying to figure out how to make it. Now remember, consumer assistance should be a bipartisan issue, right? Republicans were just as worried about this as Democrats. And yet the Republican leadership, worried about the broader political symbolism, basically turned their back on something their constituents wanted. And that's an issue we're going to have to come back to. Second, much in the way we were talking about yesterday in the roundtable, in the panel at the end of the day, it's been hard to mobilize powerful political allies in support of the consumer assistance program. And that didn't keep it from getting passed, but it's kept it from getting adequately funded. So there's been relatively modest funding. There have been 2 rounds of grants, each of them about $30 million available for the grants. Not all the states actually bid. Less than that. By the second round, some of the states that had bid in the first round didn't bid in the second round. So, you know, although the idea is strong and the foundations for connecting people are relatively persuasive, the implementation has been checkered at best. And to literally give you a visual representation of that checkeredness, this is what the map of consumer assistance programs looks like today. The dark states are the ones that got grants in both rounds, in 2010, 2012. The gray states were states that got grants in only one of those rounds, most of them only in 2010. Florida got it only in 2012. The white states were the states that just refused to apply at all. The true crosshatch states, Wisconsin and Ohio, the ones that gave it back. Notice, happy news for those of you from New Mexico. New Mexico is not at the bottom of this particular. You guys got 2 consumer assistance grants. Now, sobering news. How many of you from New Mexico, how many of you who knew health policy had the slightest idea you'd gotten 2 consumer assistance? No, you didn't, because no one's publicizing these things. right? They're a big new quasi-entitlement, a big important form of patient protection, and hardly anyone knows they even exist. Now, why is that? Well, there's some political miscalculations, I think, on the part of the Obama administration in this regard, but at the state level, the states are put in this interesting paradox, right? They've been given this money to set up these consumer assistance programs, and they have, including New Mexico, set up these consumer assistance programs, but they know they are way underfunded. So they're in this curious conundrum. Either they publicize the program and let everyone know, and then get deluged by people who need help, who they aren't going to be able to serve because they don't have the money, or they kind of lay low and stay quiet, and people do contact them, right? If you get an insurance denial, under federal law now, you have to have the name of the consumer assistance program and telephone number there. So if you get denied benefits, you get their phone number. So people do find out about them, and they contact them. But they contact them for only a tiny fraction of what they are able to do. But that's all the resources they have. So they don't go out and do outreach, they don't go out and do marketing, they don't tell anyone they're there because they don't have the resources to cope with the increased demand. So this is all bound up in the lack of adequate support and the lack of supportive and powerful political allies. But we are left now with this kind of an infrastructure. In some parts of the country, you have very robust, powerful, influential consumer assistance programs that are really there as more or less universal protections for people, whether they have private insurance, public insurance, whether they are in self-insured plans or not. These programs are there for everyone. And so they come very close to the kind of universal entitlement that connects us together with one another. But in other states, they're nowhere at all. And in other states, they're kind of halfway there, but no one knows about them, so it doesn't quite do as good in terms of building this sense of universal connectedness. So, where does that leave us? It leaves us at the bottom of our agenda for today, which is thinking about how this particular example of public support, public assistance, collective connectedness, what it means as kind of an analogy for all of you guys thinking about all the ways in which we need to build a sense of commonality in health and in healthcare. If you look through the future for this particular pathway that I've been describing to you, that is using consumer voice and consumer assistance as a model of building connectedness, you'd have to take it through a series of stages in order to get to the level of social transformation that we aspire to in this room. First off, you have to actually get consumer assistance, even for its narrow insurance conception, out to everyone in the country. It's obviously not there yet. Second, you'd have to actually broaden the scope so that you're dealing with issues of quality of care as well as access